Yeah. Well, hey, I want to thank everybody for having me on here. I was pleased and honored to be able to get back and speak at UW. Is my entire career from undergrad through faculty and everything in between had begun there. But sadly had to leave to kind of start up different things. And that was back in 2016, getting back in the telemedicine and trying to think how can I bring different types of evaluation and treatment for a lot of my really busy, high functioning patients that I had at the time. And also more than understand just how overwhelmed so many of you must be anytime you get anything quote unquote ADHD related. As you know, even in the psychiatry department, we have an hour for evals. And if someone comes in, what I call the cold eval, and is like, hey, doc, I can't seem to focus, or have you heard about this ADHD thing? And this is even 10 years ago, it'd be like that face palm, like, what do I do? How am I going to get all this data in an hour? And you guys have far less time than that. So I can only imagine how frustrating and inundated you must be when trying to manage all of this. What I want to be able to do here is let me just bring up, I'll be jumping between some screens here, but hopefully make this easier. Let me bring up some slides here that we'll be able to go through. But I know we have a short period of time, but I want to hopefully make things as actionable as possible on here. I know what for me is the better way that I could kind of manage data and how I get data from patients before I see them, so I can spend a lot more time with them, getting to the nitty gritty, drawing more psychoeducation, and then how do you really navigate the treatment side. That's where I have liked it, and it's putting some of the homework and the work on the patients. Although I know not everyone's able to control the full flow, the workflow, but I'd like to be able to help in that in any way that I can. And then also I know the other big thing going on as more recently, but the stimulant shortages are an utter nightmare. I can only imagine the stress and strain that's putting on all staff there in your departments. Patient can't find their meds. Where do you find it? How do you get it in their hands? What options are out there? And I hope obviously I can't solve that completely, but if there's anything that can shed some light on there, I would certainly like to, and anything that I've been able to find myself that's been helpful in navigating that. But in here, I'm a psychiatrist. I moved to Milwaukee to start Envision ADHD, which is my little laboratory, my little baby clinic where I got to start very small and work really with specializing specifically in ADHD in adults. Also actually finished my 2 terms on the board of APSARD, which is American Professional Society of ADHD related disorders, the specialty ADHD organization, and they're also the ones tasked and will be coming out not too long, but with the first ever US adult ADHD guidelines, which I'm looking forward to. Hopefully we have some things that we can operationalize from that we put them into practice. And I'll certainly be staying on top of that. If anyone wants info on that or some ways to integrate them into practice, be happy to share anything that I'm able to build as well. Coming in here, since I've left UW, I'm involved in a few other places. In terms of pharma, like I said, technically I'm no longer speaking for it, but I finished term with Supernus. That's one of the medications that might come up if we're talking about non-stimulants. That's Qelbree. Been on advisory committees I work a lot in technology space, so not so much on the drug development, but more on apps that some of the pharmacy companies or EHRs have been building out is where I've been more involved. I always make sure that I want everything to be laid out for the things I have been involved in. I just want to focus on ADHD and tools here. As we come in here, I want to hopefully spend some time just getting a different understanding of ADHD. I think it is just from the name alone, it leads to a lot of confusion, both in the patient as well as in our own professional space. And then hopefully get in all of the slides on here. I'll have a lot of resources, things to click through, and I'll get all of these available to you so that you'll have all of these. So even if I go quickly through some, they'll all be available for you on the back end, including the linked resources on them. But I think some of the big things in here, this is coming out of the World Federation of ADHD, their international consensus statement with all of the linked research, and should have that all linked on there in a nice way that you can actually search through all of the research quickly. But I think some of the biggest things with ADHD is it is a well-established, well-known kind of, I guess, condition, so to speak, varying degrees of prevalence in the worldwide on the conservative side, 2.5%, seeing more like 4 to 6% in more recent studies. But also, I think some of the biggest things coming out of ADHD that there's always the concern about, oh my gosh, what are the concerns of treatment? But where we actually have more data is what are the risks of under-treating, under-diagnosing, and that's, I'll bring another slide, but huge amounts of potential downstream effects, both on physical health as well as on people's mental health, crime, car accidents, accidental death, suicide, gambling, loss of job, underemployment. So I think there's something to be said about really weighing in is risks of treatment versus not treating. And there's an area that we don't have in all other areas, at least in psychiatry, where we have such tied risks of not treating a condition, not just to the individual, but to the rest of society. So many like externalities, so to speak, to other people not even involved. Coming through here, this is in 2016, but something that really stood out to me, and I remember actually looking at this study and know both of the authors through Absard, is just how underdiagnosed the condition was. And I saw, starting to see even back in 2015, 2016, kind of more and more people coming in, asking about it, seeing it. And that's when I started learning about it. And I started to see that prevalence number is one thing, but I kind of see it as kind of like even before, obviously, during the pandemic and all this, we've seen people talk about these skyrocketing rates of it going up. But even there, is we were so underdiagnosed, we're still not even hitting the diagnosis towards the estimated prevalence of even the prior conservative prevalence. So I'm thinking like a beach ball that's been held underwater for a time, and as more kind of awareness comes out, that there's a lot of room for that to continue to rise, for better or worse. And obviously, there's a lot of concern with overdiagnosis, how people are diagnosed, and I'm all about what can we do to get more consistent and standardization of that. But as we come through here, one of the things that really stood out to me, once again, are the risks of untreated ADHD, both in terms of everything medical related to the patient themselves that can stand out, to all the other comorbidities, the way, and I always say with so much of like even the psychiatric, is people, I think it's the human condition, is we want to feel in control of the driver's seat. We want control of the brake pedal and the gas, so to speak, when I think of executive function. And if we're not in control there, we're going to turn to something else. I don't care if that's a substance or the other things that start trickling down as we have to live in a state of stress. We have to, the reactions, the way our concepts of self start to very much get impacted. So to me, they use the term comorbidity, but so many of the times I see it as it's the consequence of not being in control in the driver's seat. But then the other things that really stand out, which we don't have in many of the other conditions, there's so many of the other societal things. Actually proven, treating ADHD, showing lower likelihood of commission of crime, lower car accidents, so many other parts that affect us in day to day. So something that really stood out to me before, where I was kind of conflicted, like, well, what if I make this diagnosis? What if I treat with these medications? What are the concerns? What are the risks? And this was something that really kind of stood out to me the more I found the data. And now, just to conceptualize, this is an area that I spend a lot of time with my patients. I'm just going to bring up a whiteboard here. Unfortunately, I don't think I can't seem to figure out how they do it on Teams. So this is my Zoom whiteboard. I just want to confirm, can you guys see a whiteboard on here right now? I don't know if anyone is.
Yeah, listening. We can.
You can? Okay. I was thinking, and I'll try and keep this relatively brief, but I was thinking this is when so much started to make more sense to me. If I think of, okay, what is ADHD? Like personally, I hate this term. I think it's going to be adapted. Like we'll see even definitions start to change, but attention deficit hyperactivity disorder. It sounds like we'll just sit still and pay attention, just do it. It just sounds like a willpower thing, which we know that it's not so much. And then what the heck do attention and hyperactivity even have to do with one another? And then if you take attention deficit, well, that sounds like you have an absolute deficit of attention. It's broken. You can never pay attention. So if a person ever can at some point in their life pay attention, then it seems like it would negate the entire term, which is not the case. It's much more of an extreme variability. Why is it so good in some points, but so bad at others? And that's where, and let alone what the heck, wait, a stimulant, quote unquote, medication another confusing term just because in our vernacular, these terms all have different meanings. Yet this is actually one of the longest known, technically studied phenomenons in the field of psychiatry, going well back before ADHD was ever a term, and well before there's even a single medication throughout psychiatry. And we're talking back into the 30s, behaviorally challenged boys in halfway houses getting Benzedrine after they were experimental with spinal taps to help post-spinal headaches, and could magically, like for a period of time, sit down, sit still, have conversations. I always found that fascinating. And you have to ask yourself, well, what do these actually stimulate? But if I always think, when a lot of this started making more sense to me is when I think of the brain, and my very simplistic way of looking at it, but I always think the vast majority of the brain is a lot of super important but behind the scenes kind of structures, functions, things going on. You know, your brain stem, heart rate, breathing rate, temperature regulation, keeping you alive, super important. Tons of information always coming to and from through the spinal cord at all times. Your cerebellar lobes on either side, very active, but more behind the scenes, balance, coordination, fine motor movements, visual, spatial processing, perception, vision, more in the back. I understand this will be as simplistic. My drawings in here might not be in the exact right places, but you know, the motor strip, all the controlled motor movements throughout the body, say more memory formation, hippocampus, fight or flight, emotion regulation type things in the amygdala. And often on here, when I think of this, I always think of the vast majority of the brain as this high horsepower, highly evolved, high horsepower engine that we all have. It just pumps things out. Thoughts, movements, emotions, memories, impulses, you name it, just bangs on all cylinders. That's what it's supposed to do. And even when we look at ADHD doesn't mean failure. It doesn't mean that we can't do anything. Oftentimes, you know, just IQ alone, we can get through a lot. That's why I look at IQ as kind of that horsepower. Like we know, even when we talk with our patient, like they often have glimpses of, they excel so well in some points. I always say, like, you're not living up to potential. People can see it. It's not a ignorance is bliss type of thing. It's not a cognitive delay. And often what we'll see is, yeah, we have the horsepower up here. But I always, you know, equate this is, you know, you're on a Ferrari on the highway, you know, high horsepower, beautiful day, wide open stretch, pedal to the metal, high RPM, that, you know, at high speed, that engine's humming, you feel in control, it's just kind of hugging the curves. It feels amazing. Like, you know what the potential is when you get into that state. But, you know, on the highway, as in life in general, we're going to hit those small, simple, inevitable things. The road construction, traffic, here's a bigger curve, on-off ramps, starts raining out, it's getting darker. And in all of those scenarios, I don't care how good your engine is or how much horsepower you have, because if your brakes don't work when you need them to, you're going to feel out of control in that driver's seat. And again, those out of control moments of life. And that's where I think it's not like, this is the gift, that horsepower. That's what we have. But when I think of ADHD, I'm not thinking, it's not the potential up here. That people know full well what they're capable of. Like, we're all going to have variable executive, how well in control we are there. But when I think of ADHD, or what's going on at the brakes, so to speak, that's where we often think of the prefrontal cortex, the being involved more in executive function, back behind the prefrontal, back behind the forehead, which also happens to be the last part of the brain to develop in childhood. Is the brain develops from the back to the front. So obviously, as we're aging, as kids, we're naturally having a lot of, you know, well, I always think of, like, as executive function. What I mean by this is, you know, let's just say your engine back here is pumping out, I don't know, 20 things a second. Thoughts, movements, emotions, memories, impulses, good, bad, positive, neutral, all that fun stuff. And what's going to naturally happen is all of those things are going to have to go and get filtered through the prefrontal cortex, you know, all in milliseconds, behind the scenes, subconsciously. And what this is going to have to do is then organize and prioritize, kind of rank in order of importance, all of those, let's just say 20 things. And at the same time, it's going to have to make an executive decision to be like, all right, maybe we can deal with, let's just say, the top 3 most important things at any given time. But in order to, you know, keep your mind and body here, it then also has to be able to put the brakes on or inhibit all of those other less important, more extraneous things. Or else you're just jumping all over the place, hopping all over, lost in the mix. Nothing's getting done, just overwhelmed. And that's why I look at his executive function is, the ability to organize and prioritize everything coming out of that high horsepower engine, but then ultimately being able to put the selective brakes on or to inhibit those other areas so that you can attend to what was deemed most important to begin with. And that's why what to me kind of unites all this, the underlying factor. It doesn't matter if you call it ADD, ADHD, inattentive type, hyperactive, impulsive type. The treatments have always been exactly the same and just as effective because the underlying feature is executive function. If we have a lot of motor cortex, a lot of activity, and we're not putting the brakes on that as much, it might look more hyperactive. If it's just overwhelmed thoughts, everything coming out of this, it might look more inattentive, more scattered. Or an area that's, I would not be surprised if we see it more in diagnostic criteria, but more the emotion regulation, emotion dysregulation. The same thing. What about even with the amygdala? Not saying we don't have thoughts, we don't have movements, we don't have emotions. We're supposed to have all of those. But sometimes even like with thoughts, like, hey, I don't need to think about this now. I need to deal with this first, and then I'll come back to it. The same thing with emotions. And sometimes what I see in ADHD is we might have much more, I would call it reactionary moods. It's not saying bipolar where we go to a completely different state for days to weeks on end, but more reactive moods that we don't put the brakes and something takes us over, short fuse, irritability, impulsivity, kind of getting tied to that. And I wouldn't be surprised if more emotional things will make it up into the criteria in the not so distant future. But to me, the underlying denominator is what's going on with executive function. And that's why, when kids are growing up, and we're waiting for this area to develop, it's the last part of the brain to develop, is a lot of that's externally being done for them. Parents, when they're young, literally tell kids what to eat, what to wear, when to go to bed, what to do every second of the day. You get a little bit older, you go to elementary school. You have one class, one teacher, everything laid out. Get a little bit older, you go to middle school, a little bit more autonomy, go to high school, a little bit more. And I always say, you go off to college, to me, it's the rule, not the exception, that a lot of time that's when stuff really hits the fan, because for so long, as long as you're not bothering people, bouncing off the walls, driving people nuts, or failing miserably, you might just be able to rely on your IQ, on your horsepower to pass tests. But you go off to college, it's like the first time in life where it's like goodbye training wheels. All of that stuff is immediately taken away, combined with far more opportunity and higher academic rigor. Sometimes people can just get by with IQ until they can't. So many times I find it's the rule, not the exception. A lot of times we really get a lot of those symptoms might become more unmasked in those times. So I always want to take that into account. Not that symptoms just popped up at the time, but did you see patterns, but they were kind of accommodated in different ways. And then when some of that structure scaffolding was removed, then they really showed their ugly head. Now, I think you'll still see the patterns when younger. It's not that they just pop out of nowhere. But this is where I'm looking at ADHD, is that executive function. And it's not that this is broken or it doesn't work. We all have variable executive function throughout our day. And I always say, with all of us, we're going to be in this spectrum of, at times we're doing really well. We're up here, we're banging on all cylinders, that engine's humming. And then, at least on average on the spectrum, we're all going to have a floor value down here. A place where, it's not easy. We don't want to do it, but we can get by. Maybe we can use that calendar, that to-do list, that organizational strategy. We can white knuckle it, but enough to get by. And the times where we get stimulated and we do even better. But when I think of ADHD, we have the same range there. That's just fine. But for whatever reason, at baseline, meaning like we kind of fall through the floor, like our floor values beneath this threshold. And this is where the struggle is. It's down here. You can still get stimulated and do just fine. And that's why I find if this was ignorance is bliss, it's just broken, we'd be none the wiser. It wouldn't really bother us. This is just how it is. But when we have such a big discrepancy, that's what leads to such angst, frustration. It's ego dystonic. Like, you know what you're capable of. Why can't I do this? Which leads to a lot of that angst. And that's where I find, it's not that this is broken or it doesn't work, but why does it seem like it's just not as, at baseline, it's just not as, we're not quite at that floor. And that's where we have to think of, okay, well, what activates? What stimulates this part of the brain? And that's where I generally just kind of think of three main areas of neurotransmitter synthesis and storage that a lot of the pathways will base out of. And we know the two pathways that course through here and innervate this predominantly would be one communicating with dopamine, the other with norepinephrine, or serotonin. We have some different areas going towards. But we know the prefrontal pathways here are also known to have what are called interneurons between them, which basically means that if one pathway is activated, it's likely to activate the other one as well. Could get into catecholamines that have a similar synthesis pathway. They come from tyrosine, phenylalanine, cofactors, zinc, B6, iron, SAMe, whereas serotonin comes from tryptophan, gets converted to serotonin, then on to melatonin, different pathways. But I always think how active or not active is this pathway at different times. It's variable. And that's, that can be there. But I always say, and this is what I always think finds so helpful when speaking with patients, but something we might find more internal awareness of, they might tie this more to, is dopamine also has this other pathway to the nucleus accumbens, which is, the pleasure reward pathway, which is generally activated in both directions. And so in here, we know what activates this. We think of exercise, movement, endorphins, runner's high, that gets this going. So yeah, sometimes when people are in physical exercise, especially they might be in high school, they're a lot more active in high school with sports than when they go to school. But sometimes, does it seem like some of the static, it's clear thoughts when they're in motion? Sometimes they have to be fidgeting, pacing, doing something, even if they can't. Are they moving their feet because they can't get up and walk around or do something physical? But that's one way to get the body trying to get this stimulated. Other things we know, pleasure, sex, drugs, rock and roll, that kid playing video games to get that stimulation. Yeah, magically, if he's doing that thing that gets him stimulated, this is stimulated and he can sit still, pay attention just fine for 8 hours straight. But you take away that stimulus, that same kid can't sit still long enough to tie his shoes. Or if people are doing something, they're doing something they like. They are physiologically, we're better able to sit down and pay attention to do something. If it's something that novelty, newness, pleasure, reward, it does get us stimulated. And I'm not saying it's rewarding, but we also know, I think we'll get some of this going, is the adrenal cortisol stress response. Heightened amounts, supposed to be short periods of time, does get this going. Think of evolution, like being chased by a saber-toothed tiger, cortisol gets released, we get increased executive function, because yes, in that case of being chased by a saber-toothed tiger, there better be one thing and one thing only on our mind and our body, and that's get the heck away from said tiger. If we're equally jumping between, ooh, that's a pretty flower, or hey, do you think it's going to rain on Thursday? We're probably not going to last too long. So there's some amount of what I call optimal stress pressure deadline does get some of this activated. And sometimes you might find in people's life, like, talk to them about procrastination. It's not that people just want to wait till the end or they're just lazy. But sometimes you find is they try and sit down, try and work on something in front of them, a paper they have to write or whatever. And literally it's just like worthless. Their legs bouncing, their mind's in 1,000 places. They're literally just watching a blinking cursor. But then as that pressure, that deadline rises, magically, it's like they can finally sit still, paragraphs start to flow, they get it done. It's exhausting. It's not ideal, but sometimes it becomes like a learned behavior. Like people they learn that it's the only time I can actually even function. So I might as well, you learn to rely on always being in a state of stress. And you can imagine the toll that can take on the adrenals, like literal burnout of having to live in that very low margin of error. If you have increasing function versus increasing stress curve, and people are trying to write that paper, but they sit down with 2 weeks, I'm gonna sit down and write a little bit by little bit, but I'm kind of worthless, nothing's happening. A little bit better as we get closer, but then all of a sudden, right the night before it's due, we finally become functional. But it gets too stressful, or you wait too close to the deadline and you precipitously fall off the other end. And it's almost like people learn to live life always trying to be right on that precipice, white knuckling, trying enough stress that, not too much stress that they fall off this way, but enough stress that they don't fall off this way. And that's exhausting. That's a really difficult place to exist. And once again, we're all going to have peak optimal function, executive function at that optimal stress. When I think of treated ADHD or non-ADHD, so to speak, we still have that, but what if we kind of level that curve, so to speak? So yeah, this is still optimal, but what if we could get by and be functional anywhere from say there to there, just a much larger margin for error, that can make a world of difference. And to me, like treating ADHD or ADHD, not ADHD is kind of the delta or the area under that curve. I don't know if that helps or not helps. That's how often I think of it. But it's often we find that people learn to live life always having to be in one of these states. Physical movement, activity, I don't care if it's bouncing around, bouncing a leg, pacing, only doing things that they actively enjoy and avoiding everything else. We're always having to learn to live life and adapt to always being in a state of stress, pressure, go, go, go. Because if they're not, like they fall apart. And I think even in there from like an anxiety standpoint, I always like to kind of tease this out into, we use the term ubiquitously, but I think of more generalized anxiety, I think kind of like Chicken Little, Woody Allen, there's always something negative, terrible, catastrophic, beyond your control that you can't stop thinking about. You have no reason to be worried about it. You're like, if I could just stop thinking about this, it'd be better. And in that case, people tend to fall apart when they're stressed, but they do fine when things are easy. Versus what I call procedural anxiety, which I think often more tied to ADHD, where it's like people know full well what they're capable of doing in any given scenario, a task, what's in front of them, directly related to what's in front of them, the seemingly simple things, the dotting I's, crossing T's parts of life. Like, this is so easy. Why can't they just do the simple thing? And they struggle to get there. And in this case, it's not about trying to just ease it and take that away, make them less stressed. It's like, no, they're actually needing that stress. And that's how they're getting by, sometimes thriving. And in this case, it's not about dialing it back and taking it away. It's about actually trying to level that playing field so they're not always having to live in that state of stress just to function. And on that side, once again, on the generalized anxiety, it's about, well, there's no reason to be, why are we at an 11? Let's just dial it back to an 8. Versus on the ADHD side, it's more like, well, let's get you in control of that so you don't have to rely on stress as your motivator. And the procedural anxiety, people thrive under stress, pressure, deadline. Like they're the go people whenever push comes to shove in those high adrenaline places, but they struggle with like the seemingly simple, easy, take an ER. They thrive when it's a time of a code, but sit down, you have to fill in like the box where I have to put the blood pressure or fill in a note or do documentation. This seemingly simple things all falls apart, but then they come alive during those stressful times. So again, just some ways where I tease out we use the term anxiety, but we tease out because the treatment side might be very different for each. I think those parts might not help, but that's how I look at ADHD myself. And I always just try and tease it out and drawing this out and where do people fall? What patterns do you see in their life? And then hence, if we look at treatments, hence, a stimulant, you have to ask, what does it stimulate? Does it just stimulate everything? Even caffeine, a general stimulant, gas pedal brake at the same time. It's good to the point that it's not. Or in the case of a medication, we're trying to keep dopamine and norepinephrine predominantly in the prefrontal cortex in an active state. Are we stimulating the brakes, stimulating executive function? That's going to be a very different picture than just jacking everything up. But also a long known and kind of studied phenomena in there. That's how I'm often kind of looking at ADHD and conceptualizing in a different way, but also how it's so many parts of our life. It's not just the tension and hyperactivity. It's executive function, how we deal with so many parts of life. And to me, it's really that people struggle. It's the dotting I's, crossing T's. But what I'm going to do here on there is for that, but that's stuff I like to get into. But otherwise, when it comes to diagnosis, I always think, to me, it's like a Venn diagram. I want to get comprehensive history. This is something that's really helpful to get data ahead of time from people, make them provide things like open-ended questions plus like specific kind of checklists that collect a lot of that. I like rating scales. I always like, do I see internal consistency from multiple angles? Rating scales, history, and then collateral. Someone else around them. Does another set of eyes see anything similar? Actually, I send a form so people actually will fill in their similar questions, open-ended, closed-ended questions about symptoms, how they're affected at work, home, relationships, school, and they actually fill in the same rating scales as the patient. So we actually do we see any consistency just amongst the numbers as well and what stands out? I also do some other things with some cognitive testing. I won't get into all that here. There's no specific testing, quote unquote, that'll they'll say this is ADHD or not. And even like testing of memory, focus, inhibition, that's only going to represent one point in time. And where does that fall in their spectrum of activation? So even testing, quote unquote, is only representing of one state that they may or may not be in. I equate it to like a non-fasting blood sugar. You know, did they just have a donut or not? But it's something I always just look as much overlap do we see. I obviously the criteria. These are things if familiar with DSM. Have there been 5 or more symptoms of inattention and or hyperactivity, impulsivity present for over 6 months, seen in multiple settings of their life, and have any of the symptoms been present? Have any of the things been seen since before age 12? I.e., did this just literally pop up out of the blue, or have there been any little breadcrumbs kind of seen throughout life in the past? And then is it getting in the way? Is it interfering or reducing quality of their life? Once again, it's subjective, and a lot of the strong language that has been reduced. I would still bring it up to executive function. Different criteria. There's some AAFP. CADRA is the Canadian ADHD organization, kind of the sister of ABSARD. They have some guidelines. US does not have its formal ADHD in adult guidelines out. Hopefully they'll be out sometime soon. There'll be an update at our meeting in January. We'll see where that falls. I have links. These should be hyperlinked to any of these charts if any of that's helpful. One of the things I found, it's so helpful to gather so much of the data ahead of time. If you have forms, I know it's difficult. You guys are in Epic. You don't have full control over what gets the patients and how, but I say it's so different if a patient comes in instead of just, hey doc, I want to talk about ADHD, versus they've completed all this. I have all of my documentation done, reviewed. So I get to spend the whole time really diving into it and spending a lot more time on psychoeducation, screen sharing, bringing up their rating scales. I already have the collateral information reviewed, put into my note. Do I see consistency in it? And say the more you can gather ahead of time, is the biggest thing. Happy to get into things. If you need help with templates or anything, please, they should have my email. Happy to dive into that more if any of that's helpful. I just know you have limited what you have capable within Epic, what you can and cannot do, but happy to help there. And I like, when looking at rating scales, I like just getting a smattering of depression, anxiety, ADHD, broken down inattentive and hyperactive, impulsive, and something of functional impairment. These are open license ones that can be used. PHQ-9 for depression, G87, anxiety. ASRS, you might be familiar with. There's another version that's scored, which is, I think, easier than the 6 boxes, 18 boxes with the shaded on it. I'll show you, you can link to it. And this is the Weiss Functional Impairment Rating Scale. Breaks it down into multiple areas of life and just clear, is an average above 1.5 or not? Just technically, is it showing levels of impairment or not? But I have all of these linked. But what I like to do with, here's the difference of ASRS. This is the shaded box one people might have seen. Technically the same authors, same questions, but brought over, I think, a more usable way, where it's the 9 questions of inattention, 9 questions of hyperactivity and impulsivity, the actual Likert scale that can be scored, and it actually has cutoffs for each A and B for inattentive symptoms and hyperactive impulsive. So it actually gives us something you can track over time versus just how many shaded boxes. So I like this to actually track as I'm working with patients with clear, outcome goals of, treat the target, so to speak. Something I like to do, this is actually something built way back in residency many years ago, is a way to track a lot of those scores. So everything is a 1 point in time. Say this is the first time you see a patient. I changed all names, so this was an actual real patient from back at UW. And I always just it's not what the raw score of those are, but I always say, where does it fall in the general rating scale? So I always say, when I look across at this, we might see depression and anxiety, but I would say, where's the higher level of magnitude as I look across? What area stands out the most? What falls into those higher categories? And does that align with what their complaints are? This is breaking down this is just the total of the functional impairment score. But that was one of the tie this into a context. What are they currently on? And this gives something that we can track over time. So say like, I know at UW, I guaranteed I had to diagnose them with depression, anxiety. I could never start with an ADHD diagnosis. So inevitably we work with an SSRI. And then if I was convincing enough to my supervisor, maybe I could diagnose ADHD and treat it. But I always like this is actually be able to follow how are those numbers changing over time, correlated to what are they on. I always love doing this, and it's something to share and use with the patient. If anything, patients love their own data. It's like, I'm in psychiatry, we don't get as many labs and other things to show, but something like this just gave me something where I could work through and something I still use with patients. A lot of the comorbidities, I'll go through these quickly, you'll have it, but some of the key differences to try and pick out ADHD and substance use disorder, key points, ADHD and depression. These are from the CADRA guidelines, but these will be in there for you. There's like sometimes little ways to tease out some of the differences from the clinical perspective. Actually, see what time we got. Actually, I'll try and get through these quickly. But now from ADHD treatments, I'm going to get back here and clear this whiteboard. I would say this is what I literally bring up a whiteboard with patients, and I always think of breaking it down into prescription options, therapy, and or coaching, which would be a little bit different than therapy, more formulaic, accountability, kind of setting up what are you going to do, when are you going to do it, how are you going to do it, and having that external stress, pressure, deadline from knowing someone else is holding you accountable. For services, I was thinking, talk about exercise, which we know promotes dopamine and norepinephrine. And sometimes after drawing out the brain with patients, sometimes tying this in more, I get a little bit more of a buy-in for how can we get that set up, and it gives me a better way to start bringing up topics along that. You can actually dive more into labs, potential like supplementation if people want to talk about it. My general labs, once again, go many different ways. I'm often just trying to get things I generally dive into be more vitamin D markers, more B vitamin status, often do B12 and more the downstream marker, but more homocysteine. I'm likely to go after biologically available forms of all the B vitamins in a complex. Omega-3 fatty acids, there's only some evidence of, say, fish oil, high doses, but particularly in those who had low pre-existing EPA and DHA. Sometimes I get more buy-in from patients going on high doses and staying with it if they know they have a target that they can track. Magnesium, zinc, another cofactor in dopamine, norepinephrine, iron or ferritin, and certainly if they haven't had checked that a thyroid stimulating hormone, which I don't think dive a lot deeper into it, but sometimes this is a place I generally go. I'd say this is not sort of for everybody. I always recommend that, but just the way they rule out some aspects. But otherwise in here, if we were talking depression, anxiety, ADHD, if we're talking depression, from an evidence standpoint, I can't tell you that, an antidepressant, Prozac is going to be more likely to help you than therapy, than exercise, and vitamin D supplementation for that matter. But ADHD is one of the few areas, at least in psychiatry, where we actually have really high effect sizes for medications. They're not the end-all, be-all, fix everything by any means, but it's an area where we do show a robust effect size, which I know in psychiatry we have notoriously modest, mediocre effect sizes. So in some ways, I think it can be it's often, I find the starting points, and we can always fine tune around the edges or fill in the blanks as we dive in further. But to put in perspective from a medication standpoint, just a general overview is, you have stimulants and non-stimulants. I prefer thinking them as stimulants as direct acting, non-stimulants as indirect acting. And what I mean by that is anytime we take a medication, every medication will have its own PK curve, how blood levels come on and come off after taking it. A non-stimulant like other antidepressants, it's not like you take it and all of a sudden you notice something and then you don't. It's more something you take on an ongoing, regular basis, day after day, week after week, month after month to get the benefit. And it's just that overall benefit over the day. Whereas what I mean by direct is basically anytime that level gets above some given threshold for the individual, they're likely to notice the effect while that level is above that curve. So it'll be time dependent. Maybe they'll notice a benefit from, say, that hour to that hour. If the dose is too low, they may not break that threshold, may not notice anything at all. Or as the dose goes up, maybe it breaks that threshold, but it'll be for a shorter period of time. So maybe that hour to that hour. So it's really important with this stimulant. I would say my most important questions are, what do you notice? And for how many hours do you notice it? But I always reference as well, like we're not looking for Popeye eating a can of spinach. It's not a rev, a kick, a jolt. I almost don't want you to notice in the moment. I want you thinking after you take it, am I noticing it? I would say it's something I want to be subtle. I want to be noticed best in retrospect, looking back on your day. What did you notice? How long did it last? But at the same time, you also have your upper curve here. You don't want the dose to go too high and go out of the window, where it might more on edge, jittery, anxious, overly caffeinated feel, or kind of like zoned out, kind of like the brakes are too tight. So there's really no benefit of going too high. To me, it's always about balance. Just how we bring balance to that pathway. So oftentimes I'm thinking of like just general, how is that going over time? But yeah, it's really going to be about fine tuning that dose to what I call duration of effect. What do you notice? How many hours do you notice it? And then how do we span that dosing out over the day and tie that into what people are noticing or not noticing throughout their days? That's going to break into the stimulant side. You basically have the Adderall side, which you have levoamphetamine and dextroamphetamine, and then you have methylphenidate or Ritalin on this side. Technically equal likelihood of benefit, toleration. Can't say that one side is better or differently tolerated than the other. And basically you have half of this, just dextroamphetamine by itself, and then half of the methylphenidate molecule, dexmethylphenidate. So technically we have 4 compounds, 2 of which are literally half of the other, and technically equal likelihood of benefit between the 2 sides to begin with. All the other names and different types basically then comes down to different packaging, different capsule design. How does it get released? It's controlling the PK curve. So I say if you're looking with a stimulant, you should know what's the active ingredient in it and basically what's the PK curve. So say with the shortages or things going on, if we have to change medications because of that or insurance or whatnot, I always say is if we could be as effective as possible to stay as close to the active ingredient or at least on the class side. And then what can we do to find something that is close to mimic the PK curve to the same degree? Because everything else with these is just packaging. They're all going to have an immediate release form, which is IR, which is referred to as just a solid tablet. It just basically comes on, comes off in the body. I might try and shoot for lowest dose with some of these, maybe 4 to 5 hours. On the amphetamine sides, maybe 3 to 4 hours on the methylphenidate. I might shoot for realistically. They're all going to have an example of an extended release, a capsule with beads in it. All of the beads being exactly the same as the tablet, just half have a delayed release coating. Takes a few hours to break down in the gut. So you take this, it's kind of like half right away, half a few hours later. How are you maintaining above a given level? That's what it's all about. Vyvanse lists dexamphetamine, a pro-drug, but its active ingredient gets metabolized into dextroamphetamine. Just a pro-drug, slower on, slower off, enzymatic release, basically. I might try and say Adderall XR, I might try and shoot for 8 to 10 hours. I know some things say longer. This is my realistic parts that I've just kind of adapted. 10 to 12, I try and shoot for. And I always think getting to that lowest dose, even using a week's supply, 10-day supplies, and let that kind of move up and move in small increments. Just we want to fine tune to get that in that range. But also, how long is it lasting? And if we need to last longer, is that where you might use that booster to try and extend that, say this is IR up here, or it's basically know where that level is at different time. And it really honing in with patients. What do they notice? Symptoms, good or bad? Is it happening during that window when it's active, or is it outside of it, or is it separate and doesn't matter? It might tell me, is it the med or not related to the med, or is the symptom actually better when the med's active? It helps us to fine tune. But the contraindications up here would be active, ongoing, untreated substance abuse concerns, restrictive eating disorders, and anorexia if people are using it to not eat, to lose weight to the detriment of their body, or out of control, untreated major heart concerns or conditions. So make sure we're following blood pressure and heart rate, which technically we need to do with any non-stimulant. which technically we have two approved right now, which are atomoxetine, Strattera. I apologize here. I just use names that are easier to spell and to say. And then Viloxazine or Qelbree is one that recently came out. The specifics, it's name brand only, generally for prior authorization to qualify for their $20 coupon. You have to, pretty much everyone has to have been on Strattera first anyway. You have your alpha agonists, the long-acting guanfacine, Intuniv, long-acting clonidine, Cat-Bay, technically have approval in children and adolescents. Technically, the long-acting clonidine in a liquid form got the FDA approval in adults. Don't have a lot of adults that want to use that. But some options on here. Nice things with these is there's once a day dosing. If you can get a benefit, the effect sizes are not to the same degree up here though. They can technically be used together. I apologize, and here is looking at time, but I just want to bring up on here is I have a lot of walkthrough of these, and these are some of the basically medications work from the consensus statements. I have a lot of guides here looking at some of the comparative efficacy meta-analysis of all the medications. General takeaway is yes, the stimulants were generally first line over any other type of treatment. The most it could kind of loosely conclude is potentially in adults, the amphetamine side as a starting place. You can always switch, potentially methylphenidate in children. Often I'll ask if the patient has any prior experience or if any immediate family members have any experience. Might tease one way or the other. Tend to work with extended release forms that actually came out of the study as well. I'd say just trying to make it as out of sight, out of mind. So you're looking at some comparative efficacy with other medications in other psychiatric medications, which blew me away years ago, that yes, the stimulants for ADHD are some of the highest effect sizes across anything in psychiatry. And this was this attitude neg. So user reported data on medications. And what blew me away is how the child adolescent data matched almost to a T with the comparative efficacy meta-analysis data, which I was just surprised by, but links to both of those are right there. Medication shortage, I'll be done here shortly. That's what I always say. One of the biggest things to know is if a medication is having trouble, if you do have to make changes, is to know what is the active ingredient and what are the PK curves of the different formulations that are out there. They all have different names. I understand that it's confusing as can be. Sometimes I know this is taboo within the academic side, but sometimes I found is knowing, I know it's controversial, but knowing the name brand compounds has been helpful because one, they're more likely to be in stock. If you know how to use the savings programs, they might even be cheaper than a lot of the other medications for patients, depending. But what I found is actually, you can't, but the farm reps, if anything, have been some of the best patient advocate people that I have worked with who will go to town fighting with the working with the pharmacy to make sure that they're actually running things correctly because they're incentivized to make sure that everything goes through for the patients. Not about name brand or generic, nothing there. I just want to find what's going to be effective, affordable, and available for patients. And in many ways, generic, sadly, does not always mean the least expensive, and it certainly does not mean the most available. But some tools that can help, to stay on top of all of these. Now we say the medications are simple. We have basically one of 4 ingredients and then the rest is packaging. But I have a lot of resources on here. What I want to call attention to is this Cohen's Children Medical, but I like this. If you just want to look at guides, I have this, I think I have one brought up on here. You have 2 pages to it. I have this big laminated one. I just keep it at my desk right here if it's helpful. But you'll have, these are the methylphenidate, dexmethylphenidate products. They have them lumped together. It'll show them roughly what doses are available in them, kind of loosely, roughly kind of dose equivalents. You might still have to readjust, but you can see them all laid out, extended release forms, patch forms, prodrug forms. Astaris, I'd say, is kind of like the equivalent to lisdexamphetamine, but on the dexmethylphenidate side, immediate release forms, some starting doses, a lot of info on here. So if I'm going between, say, we can't find their Concerta in stock, okay, what are the ones that are on here? Technically, I'd say this Cotempla name brand. If you know the pharmacy benefit things, you can find it at certain pharmacies. for a maximum price with any form of commercial insurance for $50, which is less than other things might be, but we have roughly dose equivalents with some of these, or on the amphetamine sides. Once again, it's sometimes just helpful to have everything in one place, and we have some things that we can kind of do some cross comparisons with if you need to. Rough and loose, but in the end, the medications are in many ways more similar than different. Know the ingredient, know the PK curve, and keep it similar to that, but you might have to readjust with the patient for that. Otherwise, some other resources. I really like this attitude and encourage sending patients there. A lot of great articles, well written for the patient population. I'll do that. I apologize for the time there because I know I want to leave some time for questions, but I want to kind of open it up there for anyone that might still be on here.